Like, question?
But you get some back.
No, that's perfect, because then she comes These was 30 minutes.
But then Karen. Yeah.
Talking to this.
But you have. No, I'll see you again.
And then she did this. She did.
Okay, so we have one of
everybody.
Right,
Right, she came because she said, okay, she's very new senior.
Okay, and Beatrice up there? Yeah, okay. She'll just stay muted. Beatrice, you stay muted. Lola, are you texting Lola or no?
No, I'm texting Niall to make sure this is gonna happen.
No worries.
Okay.
I shouldn't say
I'll stay unmuted.
Did you say tap? She's like, oh, okay, yeah, that's the American word. No, I don't think tap it is what she said.
Yeah. Oh, yeah.
Okay, so, okay, I guess.
What did we think it was?
She said, well.
That's also.
Yeah, it's both, right?
Okay, I asked.
I think Tepid is maybe a little bit more sophisticated.
Oh.
So she finally said,
You don't have to.
later, a couple years later, we got here.
Even there, so they've been in.
And,
So I think everybody's gonna have to move along.
this
Oh,
is-
really? I did not know that.
So just make like a little group over here.
Yes.
And we're
Yeah.
just. It's a little more level. I don't know.
The one, that 245.
What are you saying to?
And then 245. Wait, they're gonna move over
No.
here?
Yeah, you don't have
Yeah,
to.
stay right
Okay,
there.
perfect.
I'm good, thank you.
No, you're perfect.
So help me out. I'm
Don't.
Of course.
Yeah, it's showing my picture.
Yeah, that's okay.
See Miss Murphy in the other room.
Oh,
Really?
turn the camera on. Lola, can you just stop another session?
I can hear you.
You can hear everything we are saying.
Hi, Lola.
It's working. She was like, that tells me.
Everybody has to sit over here. Look who's here. We have two new people that just walked in. Lourdes is here and Anna's here. So they
Aw,
so
hi.
that's why we're all going, woo!
Yes.
We're doing all the.
Hello. How are you doing?
Saw you were on Zoom yesterday.
What's your
This morning.
Yeah,
Do that this morning.
Yeah,
Yeah, that feels
in my
like
house.
good. Yeah.
We really we, oh, but she lives here.
Oh, that's, so we don't need a
And I got her
microphone.
yesterday, she's staying at the house. Sorry.
You
What do you?
That's a good cut.
No.
Oh.
I know. I'll stay.
Wanted to see my part.
You are, you
Oh, I'm sure. So how long was, we left my house at 4 in the morning.
I'm not with the accurate.
5 years since.
Yeah.
So
Karen, you don't need to be on it.
I was gonna say,
You don't need to be on it.
No, it hasn't.
I don't know, you don't even with Zoom on.
I thought you were asking how long Holly waited.
No, yes.
The other place across, right across.
Oh, yeah.
Okay. So Karen would like to know if you can hear Karen and see her slides.
Because I was worried about highway traffic.
But so,
Tell me more about
slide.
I do a lot of sleep.
She's not responding.
Oh, I don't know if you hear me. I mean,
But you aren't giving my credit card.
Wow, it's been a long day already. Can I have your contact
This is why you come to the ICW, you share everything.
Yeah.
But my wife is the only one who gets pictures.
Maybe they can't see her.
But no, I call you Suzanne. Yeah.
So-
Yeah, I don't do suicide.
Okay, yes, I'm good. I
know you, then you know,
Yeah,
hey.
really. Anyway, she came and then she left. So
Yes.
if she answers. This is us.
So she had Nancy.
Okay.
Oh, did it? Oh, I don't know. Oh,
Oh.
She's in the States.
Beatrice, did you try
Okay.
But access to VIP.
Other than this IS.
Yeah, I did, she has not responded to me. I have sent 3 chat messages.
Don't get the movie disease.
But do you think she hears me through my laptop?
Yeah, so I
Because
wondered.
Lola can hear me.
Can you have your stuff muted?
I do. Okay, so that's what Lola said, but.
I was like, I could use that picture. I was exhausted. Laura's like this.
Yeah, they were focusing on the podium.
So should we go?
You have first time, right?
Oh, yeah, so
Yeah, unless they have a.
No.
Yeah, but it's not, there's so many nice things that I'm not.
Supposed to research that said that, you know, that everybody was saying, well, it's okay to sign too, it's not addictive, you should control pain first, and so we want the pension. So, and I'm sure it is, I guess it's a question.
Oh, I have.
I would.
90 years old.
Entertaining president.
If there's something else for constipation, that's being represented as pain. So, you know, all of that also clouds the decision making.
Any of the seasons.
Like we're all mad about this. So we know it's about the.
People that feel
Right.
that not everything.
Who cares about?
Have a poor quality.
But it's money.
So that study.
Young men or women.
So across the
Fly all the way across the
just
country
over.
to go to these
But
competitions.
we've done a lot of.
Like quit acting inclusive. Do they have to choose something? They're gonna have, they're gonna have to. It's gonna cost them money.
Looking at that. All of these are not classical.
Yeah, and then coming up the stairs, there's a whole bunch of like,
These are my
they have like,
That's true.
you know, like all the big tips.
I just think
They-
she's
I have sex with much better. You guys feel like
I don't have my pen to. So that's my issue. When I was around, even at the day job. That's what I mean. But in clinical, that's outside of my, I used to do that. I do that, you know.
Yeah, yeah.
So I work in a.
You know, can you hear us? Where they do the.
In the chat.
Engineering. Well, I don't know where that was.
I think I can. And my students.
Yeah.
Because I see patients and I can bring in real life.
That's, yeah. Yeah, they changed her name.
So is it?
So there is, I have to say, I face a lot of challenges. And then when my personal experience is telling me something I can also say.
I was like,
Yeah. So, for example, so
and that was exactly the process. I don't know this is
right?
exactly.
And but yet we have so
Actually, they want to do the back off.
She didn't drop.
She made sure they finished.
No, we were selecting.
She said she has to use
Yeah, we was in the office. Sorry. We'll call it that next set of surveys that we're gonna mail.
Maybe.
Yeah, the paper, so, you know, I don't know.
We ready?
if
So
we
I'm
have-
just saying, we know that they're detrimental to their health. And
We
they
need
have
to connect because
Yet
Sydney
they
is. Anyone in Sydney? I know it's 7 a.m. I don't know if you're there. Okay.
Right now I have a black screen.
We have a blank screen in Sydney. We're gonna get started here in Chicago. And so thank you all for attending our workshop about community engaged scholarship. So you can see here the great group of individuals that we have. So we have Lola, who is online with us today. And so she will be joining us here in about 10 minutes and covering the projects that she wants to tell you about. And then, of course, we have Beatrice right here from the University of Michigan. We have, I'm just using everybody's fun name, okay, that's okay. Beatrice, there you go. Yinka from the University of Wisconsin-Madison, and Teresa from VCU. And I'm Karen Parrish from the University of Michigan. And I wanted to get together a group of brilliant young faculty to come talk with you about community engaged research. So that's what we got going today. I'm just a facilitator up here, because I'm what? The grandmother.
I love it. I don't think this name's scary. It's
Forever, it's gonna be, okay. All right, so this is our aim and our learning objectives. And so we want to, in reality, talk with you about your community engaged work, about what you've done, and importantly, what are those barriers and facilitators that you face, that you experience? Because what works at Michigan might not work at Minnesota, might not work at Waterloo, or vice versa, right? So we want to share experiences. So we are going to present a bit of information, then we're going to have a big group discussion. If you read our abstract, it talked about we were going to have small groups, but we're adaptable, we are flexible, and we are going to do it a little different because we think that will enable people who may be online, who are listening, and we think that it will enable our Sydney colleagues to be involved in a better way. So we're not going to have small groups, even though we had asked you to fill out a survey so we could put you in groups. We had all that set up, and this is that. Okay, I have just a little bit. So first question, who in the room or online is aware of a framework or a model that helps you conceptualize a continuum or different levels of community engagement?
Google.
I got one little hand up. I got Tija's got a hand up. Anybody else aware of a, okay, I got two models.
Can you just define what you mean by community engagement? So I'm clear that I think. Is it?
Here we go. Maybe I should do this first. Okay, so engaged scholarship involves collaborating with community members in our research, teaching, and service to discover, integrate, and apply knowledge that benefits communities, students, science, and our own research careers. So our focus is really around community engaged research. But if you have an incredible community engaged teaching project or endeavor, that would also be great to share. Because I'm sure if you're in this room, you're doing some evaluation of it anyway, in this room in this session. You're doing some evaluation of it anyway, and that would be great to hear about. Okay, does that help, Max?
Yeah, thank you.
Yeah, I apologize. Should have put the other question second. So you can see that we have said here, community engaged research uses participatory approaches. But what I'm going to present to you in just a second is a real range. And so at one end is clearly participatory methods, but at the other end, just something much less. Okay, so we're going to present that to you. I want to go back and do this now. So now that we have community engagement or community engaged research, I could have put that. So Mags and Tejal had an example. Nancy, Beth, maybe Lourdes with some maybe. So if you have a specific framework, would you just shout it out? Nancy.
Just participatory action research.
Okay, so using specifically participatory action research. Okay, excellent. And we're going to talk about that.
Just go back to Arnstein's ladder.
Arnstein's ladder.
Yeah.
Okay, let's write that down. Arnstein's ladder. Because I don't know Arnstein's ladder, so that's excellent. And does it have different levels of engagement?
Yeah.
Excellent. Okay, so you're going to see a model here in just a second. I bet it's similar, but we'll see. Tejal, what about you?
I read a systematic review of all of these a while back, and I'm desperately trying to find it. So
Okay. So then you can send it to us.
So I can tell you, but the one that I quoted in my grant was called the Involve framework.
The involved framework. Okay. And does it allow you to engage the community, or does it talk about different levels of engagement?
So this one was different levels of engagement and different ideas to think about when you're engaging with the community.
Perfect. Perfect. So Beatrice, do I see anything coming through from Sydney?
One was just posted online.
Yeah. So do we, if there are folks in Sydney, do I mute here and let them talk, Beth?
No, they should still be able to talk.
Okay. Sydney, would you like to say some words?
Jim,
Yes.
you're already unmuted.
Hello, Karen. How are you?
Hi,
Can you
Tim.
hear us?
Yay!
Perfect. And very good. So we're good to go.
Okay, excellent, excellent. Has anyone in the Sydney room used any sort of framework or conceptual model to think about levels of community engagement that they want to share? If yes, great. If no, that's also great.
Hi, Karen. This is Inez.
Hi, Inez.
I'm just trying to think. We've used things like community action
Okay.
and participatory research to some extent. Although I don't know that we called it that at the
Okay.
time, but yeah, we have used those sorts of approaches as well. But yeah, please go on.
Okay, excellent. Okay, so what's so great about this workshop is that we have people who have experience and we have people who have less experience who are here to learn, and we can all learn from each other. Okay, so now I gave you these definitions already, so I'm going to keep going. And I want to present to you this model of, it's a community engagement continuum, and I suspect it might look similar to something that Max has used. I suspect it's similar. So you can see that there are different levels, for lack of a different term, of increasing community involvement as we go to your right. So we have outreach, consultation, involvement, collaboration, shared leadership. If you're at shared leadership, then you're really using community participatory action research. The community that you're working with is helping you identify your problem, identify what your intervention might be, understand what the outcomes of interest might be. You are in sync with that community and doing work with them, not for them, not to them, right? We can go back to consult, and this is certainly more involvement than outreach. Here, there is bi-directional communication flow. but it's more getting information to make sure you're doing the right thing. Okay, it's not really it is a two-way communication, but it's not a two-way development of your program, of your project, of your aim, of what it is that you're trying to deliver. So what this does, it develops connections. So for example, I'm sitting in a senior housing organization in Ann Arbor. We have at present 10 remote blood pressure cuffs in that setting. We have a peer support person who's helping us get to people. That was lovely. Get to people, enroll people. But we're using this as a way to begin that relationship, to initiate being present in this facility and helping them know what it is that we want to achieve and having our peer facilitator help us do that. Okay, so that's just one example that I would say we're somewhere in the range of involve. Okay, we are not at participatory. So the great thing you're going to hear today is an example from consult, involve, collaborate, and shared leadership from our 4 young faculty because they're so awesome. Then at the end of that, we have 4 to 5 questions that we're going to open up to the large group because we moved away from the small groups. And so it's just going to be a free-for-all on the questions, okay? And we're hoping Sydney can go in the chat or they can just jump in too because I believe their microphones are just open and they can jump in and say what they need to say. Okay, without further ado.
Karen, can I ask just a quick question?
Yes, of course.
So can you go back just for a second? So is there not another level that we're now talking about more? Maybe it is shared leadership, but it's really when it's the community that is driving it. In other words, we're sort of the accessory. It is definitely, there's trust, there's built, but we're hearing from some communities that, you know, they don't want to do, they don't even want to work with us in terms of they want to determine what research needs to be done for their community. So I don't know if that maybe is still in shared leadership or whether that's sort of this new understanding that, you know, there's more from the community and we're really a resource to them, I guess.
Right, so I guess I would think about that. So I think if you look here, final decision making is at the community level. I think that is consistent with what you're saying, but I think, and we're going to talk about this in our second question, what are the roles of the academic versus the roles of the community? And so I think in kind of my experience and my understanding, and you guys correct me if I'm wrong, if you're doing participatory research, my sense is that it's equal. Like you're both at the table achieving something. But what I hear Nancy saying is that the community may be doing more and just using researchers as a resource. And so I don't know if that's here. I'll be honest, I'm not sure it is. And I think that, to be candid, if you're a junior investigator, I would not tell any of them to do that for their careers at this stage. If you're me, maybe, because I'm old, I'm tenured, I can, you know what I mean. So I think that there are some pros and cons about when you might want to do that kind of thing. And so again, that's a facilitator barrier kind of question that I think we'll get to. Joanna.
I was gonna say, I think, and it's almost that it moves away from actually being research, but it's about community building and using research skills to develop a robust evaluation framework or to have this, you know, stat support in doing that. So it is that, and I do know what you mean about because you want to get the academic research outputs from things right down the end of the spectrum.
Right. Did everybody, John?
I was just gonna say, I mean, could you look at outreach and consultant with the community as the starter? So you are the consultant as the academic in these kinds of settings where they're running the show, you're the consultant, as opposed to when you look at outreach and consultant, it's often the researcher then going to the community. Now you get the community coming back the other way.
Yeah, so maybe flipping who's the driver of this continuum is
Right.
what I hear John saying.
Yeah.
I think you probably could. I think when we think about community engaged research, we tend not to think about it that way because we're a bunch of academics talking to ourselves and thinking about what our role is in the project or the endeavor. Anybody else want to comment? Caroline?
The only other thing I would say, and I think I agree with you, because I've heard a lot of communities do not want to work with the universities anymore, because once the money's gone, you're gone.
Correct.
So, you know, thinking about how do you work with the community, they develop what it is they want. I think that it makes a lot of sense to me, because there's a lot of mistrust.
Correct, there's a lot of mistrust, because historically, there's been a lot of, we're gonna come in, we're gonna do this study, and we're gonna save you, or whatever the right word is. We can help you, we can make you better, and then we go in, we do the research, and then it's done, and we're like, bye-bye. Right? So we, as investigators in this realm, have to think about what is the long-term commitment. So if I think about Ann Arbor Housing Community at the University of Michigan, like I'm thinking like a 10-year trajectory. And how can we get interprofessional students going to different housing organizations to support individuals? And when I retire, it just keeps going, because we've got either a teaching structure, a service structure, or we figured out how to fund it to keep it moving forward. And so you're exactly right, Caroline, we've got to make those long-term investments in our communities, or what's the point? We can do a grant, but then it's, and just one more comment, and then I want to let them move forward, because we have lots of time for discussion. So I want to keep us moving, because we're already behind, because, you know, this is me. Okay, up first, Teresa Salgado.
Hi, everyone. First of all, let me just start by saying that VCU has a huge, huge emphasis on community engagement, huge. And that's university-wide, not just in the School of Pharmacy or the MCV, the Medical College, well, the Medical Sciences campus. It's throughout the university. So that's the study. And then within the School of Pharmacy, we have tons of community events, from community outreach events with our students, where they go to rural areas and they take blood pressures and they do cardiovascular risk assessment. So we have several opportunities. They can go to free clinics and engage, you know, in shadowing or in service learning opportunities, like all of that. And then we also have a very developed program with housing as well. I am not super involved with that, so I didn't choose to talk about that, but it's also a place where interprofessional students come together, they learn together, and they help suppress the needs of those residents within those housing enrichment, public housing enrichment. So that's huge, and that's been in the making for like years and years, way before I got there. And it's a collaboration with nursing, pharmacy, dentistry, OTs, even medicine now is involved. So there's a huge component of community engagement and interprofessional education. So let me start by disclosing that. Now, what I'm going to present here is the diabetes prevention program at VCU that we've been working on since 2019 in June. So it's a multidisciplinary, so the CDC, and I think this is more for the international audience. So the CDC has a national diabetes prevention program, which consists of a very structured curriculum based on healthy eating and healthy lifestyles to really help people with pre-diabetes to delay as much as possible progression to diabetes. So very lifestyle based. And so we have developed a multidisciplinary with the dietetic interns, in addition to our PharmD students, well, with our PharmD residents, and we have two main locations. The VCU Health Hub, which is located in an underserved area, and it was a food desert and really needed area. And we have another location that is a more affluent area with like, it's in a women's clinic. So VCU Stony Brook. The pandemic hits, everything was in person, the pandemic hits, we moved to virtual, and at the same time, we were conducting interviews with the DPP participants with two main goals. One was to understand specifically for the VCU Health Hub, how we could engage more the participants, the residents from those areas. It was really hard to get them through the door, through this health hub, which was like a new concept, to come and attend those free classes. And so, first of all, it was very hard to even recruit them for an interview. But so we wanted to understand how we could engage them more, how we could reach out to the community. So we really consulted with them to learn more about how we could engage them. Is it through community health workers? Is it through advertising? Is it through the local police? So trying to understand all of that. So we conducted some interviews, preliminary, with all of these participants. They were all female, mean age 61 years old, and they suggested several improvements to the program. Oh, okay, sorry, I didn't say it. So first of all, to understand how we could improve recruitment and retention, and also what their experience going through the program was and what we could improve, right? So this was mainly when things were happening in person, and then we were forced to change to virtual. So program improvements proposed were some things related to the materials, but there's so much we can do because the CDC has everything pre-established. They wanted more realistic examples. They wanted to focus more on the specifics of, healthy foods and recipes and how to operationalize that. But one important aspect was that they wanted a one-on-one component in addition to the group sessions. So they wanted more regular check-ins to be able to sustain those changes that they were learning through the program. And then suggestions to improve retention would be, in addition to the weekly check-ins from coaches, to really have a hybrid model. And in the meantime, it became virtual. And so then with virtual, other problems came up and they complained about some other things. So it's just life. Meanwhile, at VCU School of Pharmacy, we worked, I say we, but really was my colleague Evan Sisson, who took over the communications course. And basically, in looking at the syllabus, he realized how much overlap there was with the diabetes, with the lifestyle coaching from the CDC to create these lifestyle coaches for the DPP program. So basically, he adapted this course to train our students to become lifestyle coaches. So every year we have 100 brand new lifestyle coaches that then we are starting to integrate and to fill the needs of the one-on-one pairing that they wanted, that the participants wanted. And so we are currently pairing our students with our DPP participants individually to either keep them engaged, to check up on them, to make up some material, make up classes if they weren't able to attend. And so that serves two purposes. It sort of addresses the need that they voice in the interviews, and it helps the students gain that exposure to real life and real hands-on experience. So yeah, basically this is what happened, and I just got carried away. I only have 2 minutes, so I'm just gonna briefly finalize this by saying that recently we are collaborating with NCPA, the National Chain Pharmacists Association. They also run a diabetes prevention program in independent community pharmacies across the country. And we're pairing our students, sorry guys, if you had this idea, we stole it now, with their participants in order to really increase the retention in the diabetes prevention program. So in summary, we made this adaptation to our program and to really pair our students in response to the needs that were voiced from the community. And then we're working on future steps, but I'm gonna turn it over to Lola.
Yes, thank you, Teresa. Can everyone hear me okay? All right, sorry if I sound nasally. I am doing you guys a good service by not being there with you in person today. COVID finally got me 2 years in and it caught up with me, but I'm excited to be with you guys virtually. I wish I could be in person. It would have been my first in-person ISPW conference, but nevertheless, I'm here to talk about some of the work we're doing at Purdue University through our Center for Health Equity and Innovation, which is currently housed within the College of Pharmacy, which is pretty exciting to have such a center that is known by the whole university housed within the College of Pharmacy. And I'm very grateful to be part of the leadership team. I just wanted to share quickly what our community engagement model looks like to date. I would say it's definitely evolving. And so we did not start here, but this is where we're at. And I just hope this will give those who are interested in doing this type of work throughout their College of Pharmacy or their areas that it can be done, and it may take time to get to this level of involvement, or I may be even creeping into collaborating and shared leadership, but this is what it looks like for us. So we start off with meeting with the community partner. During that time, we identify what their current needs are. I would say why we say this is involved rather than shared leadership is that we do indicate, you know, based off of their needs, what are we able to provide? So it's not something where we're solving the answers exactly the way they may have wanted it. We can only do what's feasible within what our constraints are. And so once we identify that current need, what we do is gather resources. We don't believe that that's something that should be laborious for our community partners. Their focus is to serve their community members. And sometimes gathering resources such as grants, such as getting student volunteers, faculty volunteers, trainees across both our public health, pharmacy, we have engineering students as well that help out with different things as well. And so that's how we contribute from the academic side, is by taking off that burden from the community partners to gather those resources to address their needs. And then specifically for our model, what we've been doing is co-creating this, again, understanding what's within the constraints of what we have to offer through checking in our partnerships outside of these community partners, but also co-locating services. I think this is very key for the community partners we work with. Most of our community partners are serving communities that are under-resourced, so food bank pantries and also homeless shelters. And so they're already providing a service that is of need. And so anything we're creating to address any other health related needs, it needs not to disrupt that. So we had to be really creative during the midst of the pandemic, whenever they were doing drive-through model at the pantry. How can we still offer these vaccination services, for example, with that, but not disrupting the food distribution? And so we think about that together to make sure our partners feel that we will not be disrupting their current workflow, and we have on-site visits to see that. We talk about how we could implement it, and they're like, nope, that's not going to work with our community. And we're like, okay, we're not going to do that. And we really have that dialogue, that back and forth dialogue to figure out how we could actually implement this. And then we implement, evaluate, and disseminate it. And that is not just in our academic sector, right? About dissemination. We need to also think about other ways to disseminate. Our community partners really appreciate us disseminating the findings as soon as we get them. So after every event, we email them. These are the number of people we reached. These are the number of people we talked about education, who actually got vaccinated, who actually wanted to, we are now doing tobacco cessation and incorporating the 1-800-QUIT line. We're doing harm reduction services through naloxone, providing naloxone and other things. And so we make sure to communicate that back to our partners. Next slide, please. And this is just some examples of what this looks like. On the left are some of our pictures that we've had at our several events, including advertising, making sure the language matches those communities that we're meeting. We have students who speak various languages, but we do gather resources such as interpreters that have really become part of the team. In our group pictures, they're there standing too, the interpreters. They come to all of our events, so they're a friendly face and they're familiar too, that we try to get the same interpreters for each event. And then our academic side of dissemination, you'll see we have posters, but we make sure to include our community partners if they would like to be a part of the authorship. Those infographics are things that we actually shared with our community partners so that they could know what's going on beyond just each individual partnership, but what's happening across all of the partners that are doing similar efforts. And they really appreciate that and are really excited. And just the short emails, an example is there too. I would just say that you just never know where this community engaged work is going to take you. I would say one thing that has really impacted me the most is when one of our community partners was planning to renovate their space, and they wanted us at the table so that they could also include things that could help incorporate what we're doing with the health services on site. That was amazing to me that they thought of us. So just know you never know where these efforts are going to lead to when you're doing community engagement. Thank you all.
Okay, so I'm gonna talk specifically about a project that we did at University of Wisconsin-Madison, actually through my program of research. And so I work with African Americans who have diabetes, and we wanted to do a program that is related to reducing medication non-adherence. And so what you see on the screen is an example of how we work with the community. And I know Caroline talked about mistrust. As you know, in the African American communities, there's a lot of distrust of researchers and scientific research in general. And so one of the things we did, if you see at the very first beginning, is we spent a lot of time in development. Now, at the beginning, we were thinking we were going to just work with pharmacists. We're going to create a pharmacist and deliver an intervention. Well, development, when we started meeting with our partners, they told us, no, that's not what we want. They wanted us to actually use individuals in the community who are doing well, taking their medicines, as the people who are actually the individuals who are going to be the conduits for the intervention. And so at the development stage, we spent a lot of time at the beginning talking about what do you want in our intervention manual? And they told us everything. They told us this is what your frequently asked questions should look like. What are you going to do when the relationship between the peer and the person ends? And so we spent a lot of time in the first picture talking about what do you want in the manual, what resources do you want, how do you communicate with the pharmacist? Every single detail that went into the intervention curriculum came from that first picture or a couple of meetings in the development of the intervention. Now, if you go to the second picture, then we have created this intervention. Now let's actually run the program. And they actually spent a lot of time in that picture talking to us about, well, we didn't really like your checklist because now we've run the program. And they were like, yeah, that checklist didn't work because we would call them they would call the person who wasn't doing well on the phone. And they said, no, change your checklist. We didn't like the location. We didn't like the food you served. Everything about even the order of the intervention component, we would have a pharmacist and a diabetes educator come in, and they told us, no, that is not the order of the intervention. You should have the physician come in and do the education first. And so we spent a lot of time even changing our intervention components based on the advice and the feedback from the community stakeholders. Now, what you see at that last picture at the very end is bi-directional communication. Now, this was very interesting. When we first started talking to the community partners, we would get all the feedback from them, but we had to change it. And so what we started doing is in those notepads, we would show them exactly what they were talking about. And right there, they would say, no, that was not what we said. Change that on the notepad. This is what you said you should do. And they were telling us right away, in real time, all the things that they wanted us to change into intervention. And then the other thing that was interesting as well is that they weren't just giving us the feedback in real time. They wanted us to be very honest. Are you making those changes right now? Or is this something that you are thinking of considering in the future? So in building trust and building partnership with communities, we created these two forms as you see. And every meeting we had, we would come back and say, this is the topic we talked about in the last meeting. This is the feedback you gave us. This is what we're changing. And because of honesty and transparency, we also told them as well, we are going to be honest, we can't make that change in the program, but we will consider it in the future. And so that was very important for us in building that trust and partnership, showing them in real time the things we were changing to eventually then be able to develop this program to address medication non-adherence, but from the eyes of the community. And thankfully, we're at the end of it, I believe it was actually a very successful program that hopefully will now lead to sustainability and hopefully get to that point of shared leadership where we are not the one taking the topic or the problem to them, but they are the ones actually telling us about it. And that is a good segue to talking about shared leadership.
So I just want to say how honored I am to be working, having this opportunity to talk to you and hearing all these projects and this amazing work that's happening in the communities around the United States. I feel really I thought I sort of had it going on just a little bit, but I mean, definitely I'm just amazed at what's happening. And I'll share a little piece of what I do. And hopefully you can see how I feel like we've run the gamut of that spectrum of that, this model, of course, of this continuum. So I am a clinical assistant professor at the University of Michigan, and I actually have notes, because otherwise I'll talk forever about this, because Karen knows, because I was her fellow. So I started in 2016 as Karen's fellow, and in 2017, I was fortunate to have Karen introduce me to the CEO, and we met of a federally qualified health center. And in that, and that was, it's in Detroit, and it primarily serves Latinx or Latino patients. And so in working with him, and then also knowing that within Michigan medicine, there is one clinic in particular that works a lot with a Latino population, I was able to start out with outreach to those practitioners and to behavioral specialists at both those facilities to establish a steering committee. And so since about 2018 or so, we formally have met, and we meet every other month. And what we do when we meet is we talk about the care of our Latinx patients. And we did in this steering committee involve community members. We don't always have patients. And so often every study or every project that we do has qualitative, as others have described, feedback where we ask, and I'll give you a few examples, where we've asked for input, and they've also directed a lot of the projects that we're working on or are going on to work. And so really the impetus for the steering committee was that we were all very unified in our desire to improve health outcomes for the Latinx population. And specifically, it was related to mental health, to depression and anxiety. And so that's really what's grounded in the research that we do. We were all bilingual. I think that's very important. I had mentioned the question about being concordant and concordance and cultural concordance. I think that is a key piece. We do have members that would not represent as Latino themselves, but they would say that they've studied or they have gone to other communities and spent time there, so that they feel that they are culturally sensitive and and have a rapport with patients as a result of that. Okay, my time is up.
No, get your advance so you get more on your slide.
Oh, there it is. Thank you. Sorry. So, and as I was saying, so yeah, and of course, like I should say that a lot of it started, so it wasn't necessarily community-based participatory research in that essence. It was more engaged because it started out with a grant that I had. And so, and I had this funding, and I came and I asked the community of the patients that we wanted to work with, I shared with them our ideas, and then they said that this is how they wanted it, essentially. And a lot of actually what we identified, even though we're coming up with like a relatively complex intervention, which of course we're going to study, we're going to try as an R1, but really the essence was what they told us was that they wanted medication information in their language, that they wanted, so language concordance, that they wanted it in a way that they could understand. So that was actually a study that we did, and that they wanted it, they didn't feel comfortable asking the pharmacist for that information in their language. And even when the physician would type in the information into the chart in Spanish, they wouldn't get it that way. So one of the projects we're working on, so the Federally Qualified Health Center has an attached pharmacy, and everything is provided in Spanish, if that's how the person would like it, because they do serve a service. People who don't prefer to speak Spanish prefer to speak English or other languages. But it's more so when they're outside of that group. So it's more the Michigan medicine patients that say more of that. But even some people who will go, they have Medicaid, so they can go outside of the Federally Qualified Health Center. And I can explain that for people who are outside of the United States so they know. But for the Latino population, that facility, a Federally Qualified Health Center, is like a safe space for them. They get all of their care there, they take their children there, they have babies there, that is like their safe space. They exercise, they get food. So it's really like a very much grounded within the community facility. And then our primary care clinic also very much grounded. So when I was able to, by the grace of God and all powers that be, like get the steering committee together and for all of us to work together because they're amazing people, that's really what I think allowed us to be, at least right now, still successful, working for 2 years and in developing projects and interacting with these communities, because they know that this group is behind all this work that we do. So, but I'm happy to answer any questions and share things with everyone. But to let you know that I do pay them. We do meet on Zoom, and that I do have like a shared Dropbox where all the information is of all the meetings that we have that they can access, as well as any of our community members. So thank you. Get it started.
So I'm gonna get us started on the workshop activities. So now it's your time. Finally, it's your time to shine. Karen already explained this. We're doing like large group session. We are monitoring Zoom. And Sydney, people, please feel free to unmute yourself and participate in the discussion as much as possible. So the first thing we would love to hear from you guys is what kinds of community engaged projects have you guys been conducting?
Did you guys get the QR code if you wanted to type anything? Sorry.
Can you go?
It's there it is, there it is. Yeah, we're not advancing to the next.
And it just has the questions in it. So if you don't want to talk out loud, you can just type some things right in there.
There you go. Or also in the chat.
Well said. Yeah. All right. So the first thing we would love to hear from you guys is what community engaged research have you conducted or planning to conduct?
So.
Max, would you like to tell us about it? No, anyone is welcome.
So there's a couple of things. I mean, and I guess in terms of community, I'm adopting a different approach. So one of the projects that has been completed. Oh, is this
In theory, we can hear, but it would help.
Yeah.
One of the projects that's been completed was we wanted to construct an agenda, a research agenda for the priorities associated with medicines optimization. And we wanted to make sure it was as inclusive, participatory as possible. We weren't targeting any specific health conditions, it was just medicines optimization. And so we had equal numbers of patient and public representatives involved with our multiple stakeholders. Sorry, there's things flashing up. I don't know if I'll just keep tell them who I am. My name's Max Watson. I'm from the University of Strathclyde in Bonnie, Scotland. And so we adopted a very balanced approach to this, and I'm going to include one of the tables from it tomorrow in the session, the workshop I'm doing with Dr. Raden Choma. But what it demonstrated is if we hadn't had the PPI representatives in the overall process, then 10 of the top 20 priorities that were identified would not have been identified and included in the prioritization, because they came initially from the PPI representatives, and it was only once they had identified them that the other non-PPI representatives began to acknowledge the importance of them. And then we had a formal ranking and voting process, and they made their way up the agenda. So that really was the first clear quantitative demonstration to me of the value of having all these different voices in the room and the importance of doing so. And if we don't, then the things we have, we're at risk of missing. So that's one of the main studies I've been involved with. Thanks.
Excellent. Thank you so much for sharing. Anyone else would like to share their experience? Beth?
This is Beth Martin from University of Wisconsin-Madison. And I think the point I want to make is I've been on several community engaged projects, and what I've recognized is how valuable stakeholder engagement is, that some of the funders won't even read your research proposal without having done the stakeholder engagement to identify those priorities, as Meg's pointed out. And the other is, as we were saying earlier, they see academia as the helicopter coming in and flying back out. And that hit me 15 years ago on my first project. And that's when I vowed I was never going to do that again. And because of our community academic aging research network, not aging academics, but aging and academic, aging persons and academics partnering together for research. And we have this amazing network in the state and continuing to build. They are now putting the issues in front of us. And so it was very helpful with a recent gain for a research program, was that the funding agency said, a reviewer said, well, I don't think older adults want this. It's like, actually, if you read the proposal, 14 of them said, yes, it is a priority. And that really helped make our statement stronger. So I think that voice, I think we're all saying the same thing. It's just so critical.
So we have somebody from Sydney who would like to ask.
Yeah, Patty from Sydney.
Feel free to unmute yourself.
Hello there.
Hello.
I can't see any of you, which is really frustrating. But anyway, hello to all our friends who are attending today. So I'd like to introduce Hadi. Hadi has just completed his PhD, but I think his PhD project is a very good illustration of this approach that you're talking about today of community engagement. So I'll hand over to Hadi, and I'm here to support him if he wishes. So go on.
Thank you. Hello, everyone. My name is Hadi, as Ines mentioned. I have done my research on a, thank you. I have done stakeholders engagement. We engage stakeholders, including policymakers, normal people, as well as physicians and hospital and community pharmacists from Saudi Arabia. We engage them to try to develop our program. It was a cardiovascular risk assessment and management by pharmacists, community pharmacists, specifically in Saudi Arabia. Then we engage their opinions, and we try to develop our program or propose some models to implement them in the community pharmacy in Saudi Arabia. So it was very useful to engage those different stakeholders groups to seek different perspectives and from just patients or people, and from high-level policymakers, as well as actual practitioners, physicians and pharmacists. So they were like very, the method was very useful for us for the development and hopefully for the implementation in the nearest future.
Okay, so was there anything, so can I just ask a couple of questions to give a bit more information?
Yeah.
What did you learn? What do you think was the usefulness of doing that? What would you have done? What specifically came out of that would help you most likely to use the program that's more likely to be more successful?
It's actually we learned a lot of things to I think to be close to actual community and try to develop something that's very useful for them and hopefully sustainable for the future, because the other research, they usually propose something without engaging community or engaging other stakeholders or some of the stakeholders, and then some of them are not that sustainable. So our aim was to build a sustainable program or a model that can be very successful. So yeah.
The proof will be in the pudding, of course. You
Yes,
have to try it.
of course.
Okay.
Thank you very much, guys. Thank you.
Well, thank you for sharing. Patty, yeah, thank you for sharing. So we are going to move to the next question, where we want to talk about what roles did the community and academic partners play in your projects, or are going to be playing in the project you're planning. I think we kind of started talking about it a little bit at the beginning. So,
I was gonna say good afternoon, but I don't think that really matters. Yeah, good day. Yes, I'm Lourdes Planas from the University of Oklahoma College of Pharmacy. And I'm working with an interprofessional group on a federally funded program looking at opioid use among older adults. And we engaged several boards. And one of the groups that we engaged were patients, obviously, to talk with them about some issues that they had struggled with and what they would like to see in terms of the care that they receive and how that is structured and so forth. And one of the interesting things that came out of that is that many of our patients wanted to invite their caregivers. And so that really changed the conversations that we had, and it allowed to have richer experiences involved in planning our intervention. It really had a different impact on how our academic detailing guide, what then later on went to the physicians, who would be the prescribers and who would be the ones who would be talking with patients and their caregivers. It really changed the way that we approached the entire project. And if we had not had the patient advisory board, we would have gone down that route. And again, if some of them had not invited their caregivers, which mostly were their spouses, but if they had not done that, then I think it would have been a very different project.
Thank you. So it seems like in this case, the community was playing a role of not just consulting with you, but even they changed the dynamics of the intervention and the manual or the curriculum that went into it as well. Who else wants to share? What roles did the community and academic partner play? Yes.
Hi, I'm Jo Heekaka through the University of Auckland, New Zealand. I'm involved in a project at the moment where we're developing a injury prevention intervention for older adults. And so our community partners, we wrote the grant with them to apply for funding. And so they've been involved all the way through. They have directed us on, so we did interviews with over 50 people on, what the training should be for the people delivering the intervention, what was missing from the current system, so that we've been able to feed out more widely rather than just the intervention. But I was just going to say, we had people, so people from the community that were transcriptionists. There's an advisory group. They've, there's lots of different ways that we've been involving the older Māori, older Indigenous populations in the work we're doing. So there's, roles as well as, named investigator roles, but also then the, sort of more day-to-day jobs that are being done by community as well.
Oh, thank you so much. That's interesting that people from the community helped to transcribe the data.
Yeah, and I mean, sorry, I was going to say we pay everyone, so it's not like we just, it's not a volunteer thing, it's funded.
That's amazing. And you wrote the grant together, you said too. So that's an interesting, very innovative way. Yes.
Nancy Waite from University of Waterloo in Canada. I work with Kelly Grinrod on a vaccine hesitancy project, and I'm just going to tell you the interesting part, I guess, about our community engagement is we don't know who to talk to, like at all. We don't even, so basically our community partners tell us which communities we need to talk to, and actually then they say often you can't talk to them, so we'll talk to them. So we're so in some ways very removed from our community partners, and that's on purpose. They want to be protected. They're very sensitive. There's a lot of trauma in some of the groups that we're working with. There's a lot of feeling that we will, when we talk about going to a Black community, for example, they just like look at us and go, there are many Black communities, you do know that, right? And we, of course but so they really help us navigate that whole community experience, not just what they're saying, but even who to talk to and how to navigate that. And a lot of control on their end in terms of working with the people in the community.
Yeah, so I think that's very interesting. You said something about they took control and it helped them to navigate the space. And I think that's very important to mention. Thank you.
So Tejal Patel, University of Waterloo as well. We haven't started this project yet. We're planning the project and we're working with stakeholders to determine what the outcomes of medication reviews should be. So we're working with patients and mostly older adult community and their care partners. We have invited community pharmacists as well as clinical pharmacists or pharmacists who work in clinical environments. We've invited physicians, including geriatricians, and then we've also invited administrative staff at different clinics to help us understand what outcomes are of relevance to them so that we know what to collect in terms of data, and we know how to design our data collection to really hit those people, because we keep coming across different professionals who say, well, that review didn't tell me what I wanted to know, and didn't give me the answer. And then patients don't even know what a med review is, or they're going through one. So I don't know how challenging it's going to be when we finally design the project to be able to collect all this data and to address all the outcomes that the different stakeholders want. But that's the way we're approaching it. And earlier I had raised my hand because I had a question. And the question was, how do you determine adequate community representation? So one of the challenges we're having with this planning meeting is how many people are enough, how many are too much, and how many are not enough, and they represent their communities adequately. Thank you.
Thank you so much. So you said a lot: data collection processes, figuring out the outcomes for the data coming from the community. That's all part of the research process. Most of the times as academic partners, we don't even think about, like you said, having somebody from the community even transcribe the data, navigating the whole experience of who do I even talk to in the community as we do our research projects, and that coming from the community. I think those are all great perspectives on how the community and academic partners play different roles. And so that's interesting. Because of, are we able to move on to the next question? And we are going to come back to your question.
Well, actually,
Yes, I don't want to
Sydney
forget
from
that.
Sydney does look-
Oh, somebody from,
Sorry.
okay, Sydney, you have a story?
Yeah, hi guys. It's Beck from Sydney. I just wanted to share a quick story of a project that Sarira and Claire and Tina did this year around mental health first aid and developing cases with patients with lived experience of schizophrenia. And the process that we used was actually with these patients who had schizophrenia, and we developed case studies for our students in the classroom. So instead of us making up a case from scratch, we actually worked with these people to hear their stories, but then we, with them, turned their stories into a case study for our students. In fact, 3 different case studies, one with a patient who is first suffering from psychosis and enters the pharmacy and is looking for, earplugs because they're hearing noises, which was in fact adapted from someone's story who he said, I kept wearing earmuffs because I kept thinking everyone was yelling at me through the cars and things like that. So it was amazing to work with these people and hear their stories and then turn them into case studies that we've now tested in the classroom. And what we did we validated them first as well with consumers, again, not the same ones that helped us develop, but another set of consumers and psychologists and psychiatrists. And then we used them in the classroom this year, and we had consumers come in and watch the students role play with actors, trained actors, to act out these psychosis cases, but then have consumers to provide feedback to those students on how well they performed and how they perhaps could do better. And I loved the process that we used this year, and working with another student where we're going to do something similar, but with Aboriginal and Torres Strait Islander consumers to develop case studies for the classroom. So thanks.
Thank you so much for sharing that. I think that's very innovative to have lived experiences from the community we use in a classroom, because like we talked about at the beginning, community engagement is not just research, but it's also bringing that into our classrooms and our teaching. And so I really like that idea of the case studies and having them come and see them actually do that. And it's a way of kind of closing that feedback loop with the community, continuing to build that trust and transparency. Like, you told us this, we did it, come watch us and see what we did with what you told us. So very innovative, thank you. I heard Lola, you had a question or you had a comment?
Yeah, I was just going to respond to our colleague's earlier comment about like, how do you know how much representation is enough? And I would say, in my experience, that's a tough question. Like, I'm asking myself the same thing. I can just offer some things we've come together to determine ways to hopefully help facilitate that process. I don't think there's a hard and fast number, just like there's no hard and fast number for qualitative research, the number of participants. But I will say, in the work that I'm doing with our State Department of Health and community health workers and addressing health disparities, we're creating councils across the state where we're hoping to engage community-based organizations to help inform our efforts moving forward. And our major question is like, how many community-based organizations need to be represented across the state? And how do we select who will be? I'll say that we're starting with the very basics. So really defining what our goals are and really mapping how each person could contribute to that. I know that doesn't help reduce numbers totally, but it did help us clarify whenever we were saying, oh, this person needs to be at the table, this person. But when we went back to our goals, it helped us solidify, actually, these are the people initially that would really align with our goals that we've identified. And then we're also doing a self-selection process where we're opening up applications to join. We're having councils. I'm not sure in which way you're engaging with communities, but some type of process where you can invite people to apply. And when I say apply, it should not be a laborious process. We want it to be very simple, but give them the option to say, based off of these goals, do I feel like my organization is in alignment with this? And am I even interested, knowing that these are the goals? And so those are some of the measures we've taken so far to help us define how many people, and at least if they're the right people. I can't say we have a number yet, but I will say that feasibility is a big thing. We're trying to pay members of the council, and that will also help dictate how many people we could take on to. So hopefully that is just some helpful information.
Go ahead.
Hi, it's Max Watson here again from Strathclyde. It was just in response to Giles' question. There's two things. One of the things that I always try to do, if it's a multiple stakeholder engagement process, is to make sure that we always have balance in the numbers. We have equal numbers of patient public representatives compared with the others, whoever the others may be, because we know that the whole power differential thing is a really big issue when we're having engagement of any sort. So at least having equal numbers, whatever those numbers might be, is one step in the right direction. And the other thing I would say is, how many do we need? I think so. The way I approach it is, I don't think there's an answer. It depends what you're asking, who you're asking, what you need to do, and what what the overall aim is. But say, for example, if you had a multidisciplinary group and you had a general practitioner, a general medical practitioner representative there, you don't expect, or we wouldn't expect that GP to be the voice of every GP. So it's that he or she would be a representative from general practice that has lived experience of general practice and some knowledge and understanding of the topic of interest. And I think we can kind of be gentle on ourselves as researchers and acknowledge that if you have PPI, patient and public involvement representatives in any discussion or whatever, again, they're not going to speak for everyone. They're going to base what they're contributing on their lived experience and perhaps the wider world, but we can't expect them to be the voice of everybody either. So it's just, I try and bear that in mind when I'm adopting a kind of sampling approach to these sorts of activities.
We actually have another comment.
Thank you. Oh, a comment?
Yes.
Okay.
or question, I'm not sure. Go ahead, Sydney.
Okay, all right, hi, it's me again. So Inez, speaking, what I'd like to, a couple of questions. I think I need some clarity here because what we've been hearing about, I guess, to me, in my mind, there's a conflation between what we do in terms of research to try and advance our contribution to healthcare as pharmacists. And then on the other hand, what I'm hearing about is really some true community engagement activities or projects, which some of the presenters have described, and they've talked about we. And I don't really have a strong handle on who the we are. For example, Karen talked about a committee that's been set up in her institution. Who are those people on the committee, and who leads that process, and so on? So I guess I just need a little bit more clarity, because I think we're talking about a wide spectrum here. We're talking about engaging the community in our research projects, all the way through to actually getting really involved in community development, which is a much broader agenda. So perhaps this is a question to all of you who've talked about your projects. Perhaps you could provide some clarity around that.
Okay, so just to confirm, you're asking, when we say community, who are we describing? The we?
So, yeah, it's not just the community. The community, you're talking about different stakeholders, different target groups within your population, I presume. This is where I think we've got a bit of difficulty because we have a very different structure here in Australia. And you have, when you're talking about your community, I presume you're just talking about the people in your town or in your neighborhood or in the university, or, I mean, you have to define what the community represents in each of those settings, who they are, and who are the people actually who are on these committees, who are actually initiating these engagement processes. I guess that's what I'm trying to get a handle on. Does that make sense?
No, that makes a lot of sense. I mean, I'm gonna I kind of summarize different things I've heard. I've heard housing authority people. I've heard patient and public involvement is what I heard, for at least for the example I gave. I talked about peer advisors in the community who are from racial and ethnic minority group, African Americans, people who do have lived experiences with diabetes, being part of this community of interest. I've also heard pharmacy partners, I'm trying to see what else we've heard in terms of what exactly is the definition of community. Anything else? Community health workers. Community health workers. I don't know what they would be called in Australia, but something similar to it. What else have we heard?
I guess my sense would be that if you're talking about community engaged research, it's incumbent upon you in your communication to describe who your community is. And so, for example, in just the brief example I gave, I didn't have a slide, but I am working with some academics. So we have 2 academics, we have a social worker, we have a pharmacist, and then we have individuals at the Ann Arbor Housing Commission at the organizational level who are involved with us, as well as at the specific residential facility. So, I mean, that's just an example. And so when I go to write about that, I've got to describe that community. So I'm not sure we're saying different things, Ines. Maybe you think we are, but I don't think we are. But I think in this workshop, everybody has a different community, and we did not bring one community to talk about here. So
no, yeah, that's fine, Karen. I mean, what you said now was a clarification, in as much as you described who you were. So it was a social worker, yourself, and you just described who's involved in I guess, initiating and continuing this process. So that's important. But it was your idea, or it was, I mean, is this sort of coming from your vision of
That,
how-
that particular project is, yes.
Yeah, okay.
That particular project is because our university needs to be more involved in our literal Ann Arbor community,
Yeah,
like
okay.
literally in the city. And so what can we do at our university, in our College of Pharmacy, with the resources that we have to have an impact on the health of people in our community? And we went to an organization in our university that helps us build different partnerships, that helps us build partnerships in the community. And Mary Jo said, Karen, I want you to talk to these 2 or 3 organizations. Which one seems to fit best with this long-term thinking? And so that's how we got there.
No, that makes sense. Thank you. Also, just a sort of a follow-up question. So how, you know, all of this is a lot of effort and takes time and resources. I guess the back of my mind, I'm asking the question, how is this, how can these activities be funded and sustainable? Does it depend on getting research grants to actually define a specific project, or is there a quantum of money that's available within the university to support these kind of outreach activities? How does it work?
No, thank you for that question. That is a good segue to question 4 about talking about, we all talked about it's going to be positive, right? We know we need to do community engaged research. We need to involve stakeholders, but what was positive and importantly related to what Ines just asked, what was challenging about those partnership experiences? What did you wish you had known? And I think Ines, you kind of started us a little bit about that. Oh. I can start. What was positive about the project that we did was the fact that we were able to build the trust with the communities, especially because I work with African Americans, like I mentioned at the beginning. It was very hard. You can't just come into the community. You know, a lot of people think because you look like this and you look like them, it's easy to just go into the community and start a project. No, it doesn't work that way. But because we took a lot of time, and I would say maybe that is one of the challenges, positive in that we took time in building that relationship with them, communicating, like I said, about every single detail. So that was positive because it allowed us to build trust. However, the challenge with that is that it took a lot of time. It did a talk of time. It's not just a one-time meeting. It's not, I see you and then I don't see you again. It's like you take time to get to know the community before you even come in and bring in your project. Like you just go in and just say, you know what? I just want to come. I just want to get to know you. And so we spent a lot of time going to churches, going to community organizations, and just saying, this is just a get to know you relationship without any agenda. And we did that for a while before we actually then went ahead and say, okay, now we have this idea, we have this thing we want to talk about, and we want you to be part of our patient or a peer advisory group. So I would say time was one of the challenges in building that partnership.
Nika, if you would go ahead and talk about that next step, about how you funded that and how you think that's going to be sustained, because I've heard you talk about that in a different audience.
Okay. How we spent time getting the funding?
No, that's how you did this, was with funding.
Oh, with funding. Oh, yeah. So the nice thing about Wisconsin, and I know Beth can attest to this, is that through our CTSA, which is, oh man, what is the equivalent of clinical and translational science, they actually fund you to do a project which is all about stakeholder engagement. And I believe PCORI, which is in the United States, also has that, where they actually give you money just to spend time building partnerships. And so that was very helpful to be able to find a funding agency that says, we will give you money to spend time to plan with your advisory group, to develop your research question with your community, to spend all that time. But you need to find an agency that is going to do that. So I guess that is also the challenge with that. But I think a lot of people, a lot of agencies are looking for that now. And I think like Betty was saying, if you don't even have that in your grant, they don't even want to look at it. But there are specific grants and funding that are related to that as well. Look,
Oh, I don't want to interrupt you, but I have something from Sydney.
Sydney, okay.
Yes, so they, I'm not sure exactly who said it from Sydney, but they said ethics applications can be very tricky. Working with Aboriginal and or Torres Strait Islander people has special ethics, and this requires lots of letters of support from community members, and it's tricky and takes heaps of time too.
Yeah, thank you. So they talked about time, but now the ethics around even establishing the relationship and.
Well, I think she's just saying like the actual ethical application. And just all the approvals from the community.
From the community,
that you may
yes.
need
We might see.
to convince your IRB that you're ready to do this.
Yeah.
But also
Yeah.
with tribal nations
Yes.
in the US is similar.
Yes, I'm-
Indigenous.
Oh, I was gonna say, working
Yeah.
with tribal nations in the United States is also a very, very similar process, and historically a very tight organizational structure, and then obviously lots of mistrust, but I think we have similar experiences here in the
Yeah.
US.
Absolutely. Go ahead, Sydney. Go
Yeah,
ahead.
so just my experience now putting in ethics applications through the AH and MRC, which is the Aboriginal Health and Medical Council, is just, it's just really, really time consuming. And, you know, the applications are only reviewed certain times in the year. So you need at least a year sort of before you can even start the project. And in fact, it feels like you nearly need to have done the project to get the ethics application, because you want to speak to community, but they already want you to have spoken to community to say it's okay to speak to community. So it's challenging. I've got some fantastic Aboriginal and Torres Strait Islander partners assisting in the work, but it's just tricky. And I know that there are some people from New Zealand here in the room at Big Ten conference as well, and I'm just wondering if it's the same with working with Maori community.
Yes, 100%. So ethics, but also our research applications, our national research body now will only, the part of the review criteria, 20% of it is allocated to Māori health advancement. So there needs to be a true, you know, incorporation throughout the research proposal of the intent to improve Māori health advancement through all national health funded research now.
Thank you.
This is Beth again, and you know, this is we call them the Las Vegas rules. What's said here stays here, but what's learned can leave. But you know, Yinka and I in our university, so she told you it has taken a lot of time to establish that trust relationship with the community. Then we have some colleagues who haven't been social scientists, who have reached out and said, you need to come do this opioid research with us. You need to come do this. And they look at Yinka and our other colleague and say, who are these guys? Who do they think they are? They're just going to show up at our doorstep and expect us to participate. So it's that respect of our research enterprise and colleagues and how much time goes into building a trust in the community and that stakeholder engagement, because it can wipe that trust out so quickly. So it's more of a challenge or a warning than anything else.
Thank you.
I just want to mention something about the challenges, because it's something that I've come across a few times. And it's you know, you've seen one college of pharmacy, you've seen one college of pharmacy, depends on, you know, how things are. In some places, you might have very well-established clinicians, pharmacist clinicians in federally qualified health centers, in family medicine clinics and so forth. And so here we come with what we would like to try to do, what we've been describing here. But if they are the caregivers, they might think that they don't need us, okay? And then sometimes our way to get access to the community might have them as an intermediary, have the clinicians or clinical pharmacists as an intermediary. So I'm just mentioning that as a challenge, and if anyone has had any issues with that, I mean, how do you come across it? I mean, I think you give the example of the pharmacy at the federally called FQHC. So, you know, you might have a pharmacy there, but what if the clinic that's connected to the pharmacy already has pharmacists that have been there and they're very entrenched, they know those patients. But yet here you are coming in, and then they might say, well, it might be, who are you? And so like, how do you work with some of those issues?
Well, it's ideal when you're the same person.
Yeah.
And that's kind of where it's at.
Yeah. What if you're not the same person, I guess?
Yeah, you're right. It's collaboration, it's partnership, it's making sure that everybody has like the same goals and seeing what their availability is. But yeah, I agree. I mean, I would say the community pharmacist in the clinic that I work with, it's not necessarily the same goals, but willing to, oh, we got 1 minute. Okay, so I guess I need to cut off but yes.
I'm making that up.
No, we're gonna do a summary, but thank you so much. Yeah, it's a great question.
I'm making up the fact that we have 3 minutes, Beth. So one of my colleagues who worked in this Center for Community Engagement that we partnered with to identify, anyway, she said to me, she said, there are 3 ways to sustain something at the university, in our universities. Research funding, it's incorporated in your teaching, or it's in your service delivery model. And so we have worked to think about how can we incorporate some of our community work into teaching. I think Beth is a great person who's done that. Teresa just gave great examples of that. And then Yinka's given great examples, and Beatrice great examples of how the research funding can sustain or begin to sustain the work that they're doing. I want to call out one organization, VCU, because they started with research funding in their housing community project. And over, I want to say almost a decade, and I know this because one of the people who was in it came to Michigan, so that's how I know that. And in the end, the health system had to take over funding this, and to recognize, or your health science deans had to get together and recognize this is a role in our university we need to be giving to our community. These are the resources that we need to give, whether it's people, could be people, doesn't have to be cash, but could be people, and maybe a little bit of cash. But if we think about sustainability, all of us in this room have to think about those 3 things, I believe, as the model. Okay, one thing to summarize. So I just wanted to comment that you guys have given some incredible examples of what your communities are doing to help you with. They're helping you develop interventions, construct a research agenda, which I did not hear enough about. And so Mags, I am after you in just a few moments. To engage with them to understand how we can improve their involvement and their participation, to develop an academic detailing guide, to participate in our research endeavors, meaning help us identify, write the grant, do the transcription, help us identify what those outcomes are. So this group has amazing experience in, I'm going to say the word partnering with our community, not using our community, partnering with our communities to help us with our work. So I think we've given lots of examples. As you could see, we ran out of time on the sustainability and the barriers, but I think even in our conversations, we identified a few of those things. I want to thank everyone for their participation and for your patience with our technology and with our approach. Thank you.
So Lola recommended, Lou just said, practice-based research networks. Those are suggestions.
I mean,
Yeah. You're not.
No.
Together as many people. No. Not in well. And then.
Yeah, it sounds like all the way little
that much.
And I'm never confident.
Stephen, we see your comment.
Yeah, Sydney must have closed it out because we had.
Because we're done.
People closed out too.
Okay.
Because that's the only way they can reset, record.
Got it.
They got another session in that room. They gotta get that